And now, live from the Newman Library Athenaeum, it's Vox Humanities Conversations with your host, the director of the Center for Humanities, Dr. Sylvester Johnson.
I'm Sylvester Johnson, and this is Vox Humanities Conversation, a live streaming program from the Center for Humanities at Virginia Tech. As with all productions under the Vox Humanities Media imprint, the Conversations initiative places its focus on the advancement of human-centered knowledge. We do this by engaging with experts and scholars whose work explores human life and human culture through a critical lens, and which serves to enhance public understanding around the impact of social disparity in a complex world. What makes Conversations unique is an emphasis on sharing stories that connect us to the humanity within the humanities. For each episode, we'll invite one or more guests to open a window onto the story of their scholarship, both the story that stands behind their work and the story that lives within. We are living amidst exciting times of new discovery and opportunity, and yet our world is also shaken by tremendous challenges. This has been especially true over the past few years as communities and societies across the globe have faced natural disasters, wars, persecution, and the ever-changing difficulties of the global COVID pandemic. Our social institutions, our universities and colleges included, have been forced to reckon with the toll that these challenges can take on the lives of people young and old. And unfortunately, the pressures that such difficulties can bring too often undermine mental wellness, can lead to depression, and even suicide. One university in the United States lost at least 3 students to suicide in a single year during the pandemic. Our guest today, Professor Jody Russon, is no stranger to these issues. Her research is dedicated to vulnerable youths, particularly LGBTQ+ adolescents, and young adults struggling with suicide, depression, trauma, and disordered eating. Professor Russon's work is meeting one of the most important challenges faced by young people today. Welcome, Professor Russon. We're so glad that you could be with us.
Thank you. It's good to be with you.
So maybe we can begin by just briefly telling us what your role is here at Virginia Tech.
Sure, absolutely. I am an assistant professor in the Department of Human Development and Family Science, Marriage and Family Therapy program area. And my specific focus of research is suicide, and particularly how we prevent suicide and how we intervene with suicide. I'm the principal investigator of a research team that is called ASPIRE, and that stands for the Alliance for the Study of Suicide Prevention and Intervention Through Relationship Enrichment. So the idea of ASPIRE is that through relationship building, through connection, we can face some of these problems that we're struggling with.
That's that's really an important area, and I'm eager to hear more about this. I'm wondering if you could tell us, when you're doing your writing or your research or your teaching or any of your engagement, what is at the forefront for you as the most important thing that's at stake, so to speak? If there were at a philosophical level something that was really identifiable as the wind in your sails that's propelling you to do this work, what are one or two of the things that you would identify?
So that's a really good question. The wind in my sails, what energizes me, what keeps me doing what I'm doing. And I would say that it is 2 things, and they both exist in the name of ASPIRE, which I developed as a representation of that. The first is the commitment to suicide prevention, the commitment to saving lives, to addressing the challenges that people face that make them want to die or make them want to hurt themselves. And so that drive to prevent suicide, to find the right interventions to address it, is a real core focus for me, with both professional and personal roots. The second part of that is that relationship enrichment component. I am a family therapist. I train students, I see clients, I work with wider systems to improve healthcare. And so the idea that we can cultivate relationships that can strengthen our ability to survive and thrive is really essential to what I believe in. Whereas a lot of intervention approaches may focus on cognitive changes, behavioral changes, I believe that relationship shifts, connection, quality of the relationship can propel that change and therefore result in both cognitive and behavioral differences.
Can you say more about some of the challenges that young people face? And you've seen from your research into this issue, and as you have worked to try to develop ways to intervene, what are some examples of the difficulties or the problems that you've seen? What do you think is driving the root causes behind this? So let me speak broadly at first, and then I'll get focused on the population I work with, which are LGBTQ plus youth. Okay. But there's a really wonderful theory in the field of suicidology developed by Thomas Joyner that talks about the interpersonal influences behind suicide. And Thomas Joyner identified two constructs that fuel the desire to die, and that's thwarted belongingness, feeling like we don't belong anywhere, we don't know where our network is, and perceived burdensomeness, that I'm too much for others, or I can't live up to the standards of others, I'm too much in general. And this is a really well-researched, robust theory, and it brings us to the acknowledgement that our connections and relationships with others are highly impactful on how we view ourselves and our lives and our worth. And as somebody who's also interested in attachment theory, which it describes the basis of human connection, particularly from our infancy, you know, as relational beings, of course, we rely on each other. Of course, we are designed to connect to others and are most healthy when we do. And so when we're in situations where we do feel isolated, or we do feel othered, or we feel as though we cannot connect or relate to those around us, that has profound consequences. And so if we think about the pandemic, if we think about the massive changes in how we relate to each other and where we relate to each other, those platforms, we have to consider these factors. And then to get more specific for LGBTQ plus youth, we find that in these communities and in these populations, there's both higher rates of suicide and also higher levels of suicidal ideation. And we have to think about that from a contextual perspective. I think sometimes we get kind of lazy and we say, you know, being LGBTQ, that's a risk factor for suicide, and that's not true. That's not the whole story. In fact, when we say that, we risk pathologizing identities.
And so we really have to think about the mechanisms, the why it is that a certain population, a certain group of people may be at more risk. And when we consider, particularly for youth, issues of discrimination, marginalization, family conflict, ideological differences that exist in families, increased homelessness, bullying at school, and we consider those with the knowledge that Thomas Joyner brings us about the interpersonal theory of suicide, we kind of see this perfect storm emerging when it comes to youth being at risk for factors that aren't related to identity, but the contextual, sociocultural factors that influence them.
No, that makes sense. It's not necessarily that people are who they are, it's
Right.
it's the social pressures around them that determine their ability to thrive in some ways. Do you observe, or do experts observe a difference in the rates of suicide among older adults versus youths?
Yeah.
Or is there similarity in the occurrence of suicide and depression? What are you seeing?
So the suicide rates and risk vary across different populations. We know from data from a few years ago that for youth populations, many of my primary care providers are surprised when they hear this, but suicide is among the top causes of death for adolescents and young adults. And then depending on the contextual factors for older adults, particularly veterans, particularly those with trauma history, particularly those who live in isolation, we can see some increased risk as well.
There's actually a follow-up to that. So, you know, what you're pointing to, this is such an important issue. It's one that can hit home for so many people in many different ways, whether it's affected their immediate families or their extended families or their friends, people in their community networks. And as you're pointing to, unfortunately, this is something that happens a lot. I was opening with the example of one university where several students in 1 year at that one campus died from suicide. And yet, it's not easy for people to talk about suicide in our society. And I'm wondering if you could share your thoughts about that juxtaposition. This is something that unfortunately happens too much, but is not something people at large, I mean, experts like you talk about it, but most people at large don't really talk a lot about it, and when they do, it can often be very uncomfortable. Can you say a little bit about why you think that is the case?
Yeah. You know, in the family therapy world, there is a saying that you are only as sick as the sickest secrets in your family.
Okay.
And if we kind of expand that to a societal level, what are the secrets that we're keeping? What discourses aren't we discussing? And what does that do to us when we don't discuss them? And I think about our conversations about suicide in that way. And we find there's actually a lot of really great suicide awareness gatekeeper trainings that have emerged. And across the board, the hands down consensus is that we have to ask directly about suicide. When we're concerned about someone, we can't say vaguely, are you wanting to not be here anymore? Are you really upset that you don't want to talk about it? We have to say, are you thinking about killing yourself? Are you thinking about suicide? And you know, a lot of people are afraid. They're afraid that if they say that directly, it's going to implant a thought in someone's mind, and we just find that that isn't true. If someone isn't thinking about suicide, they'll tell you that's not an issue. But if they are, and you can see them there, and you can tolerate being with them there, then you're in a position to provide them help. So one of my mentors says all the time, you know, we can't be afraid of suicide because the family that we're working with or the community that we're working with already is. So we have to be the person to be upfront and direct about it.
No, that's profound. That makes so much sense.
Yeah.
But I imagine also there are all kinds of challenges in trying to make possible those interventions and strategies. So I'm wondering if you think over the past, what have been either widespread cultural or professional expert approaches to trying to support flourishing and the nurture of people who otherwise might succumb to these pressures. What do you see as having shifted over the years? Are there best practices now that are happening among experts that were not happening before?
Yeah. There's been a lot of changes on both the intervention and the prevention side. There's been a lot of great tools being developed to screen, assess, refer, the SBIRT model where, that screening, assessment, brief intervention strategy, it's being implemented in schools and other community settings. And the idea is not only are we identifying folks that might be at risk, that we need to help, but also can we expand a culture where we're able to talk about this, address it directly, and target these issues more effectively. On the treatment side, there's also been a lot of growth. Unfortunately, when it comes to youth suicide, adolescent suicide, there are fewer empirically supported, tested therapies, psychosocial interventions for that population, but they have been increasing. The approach that I use and study is called attachment-based family therapy, developed by Gary Diamond, and Suzanne Levy. And what's been really interesting about the development of this approach in particular is it goes back to what we were talking about before, whereas other models focus on cognitive change, behavioral change, may involve the family as an additional module or for skill building. The target of attachment-based family therapy is about repairing relationships between children and caregivers, including caregivers of choice, and using that as the primary mechanism to treat the suicide. And so the advancement of not only relationally informed approaches, but also modular treatments that have a bit of behavioral therapy, cognitive therapy, family therapy, and building approaches that are unique and specific to each client in a very family-centered way have been some of the major advances that I've seen.
Yeah, I was thinking, just wondering, in the work that you've done, what you have actually discovered yourself, because you spend a lot of time teaching others, training others, preparing that future talent that's going to be of support in our society. But I was going to ask you, what have you yourself discovered that has most struck you from the work that you've done?
Yeah, I feel like I'm learning every day in this work, but let me talk about it on like a broad scale, if you don't mind. So within the field of suicidology, I focus on prevention and intervention work, but then within that, I identify as an adaptation, implementation, and dissemination scientist.
Okay, so what does that mean?
Yeah, so what does that mean? It's a mouthful. It means that, we have invested so much time and money and energy in developing psychosocial interventions, therapies in a lab setting or a university setting or in a center. And we haven't invested as much time and energy in how these empirically supported, tested, successful treatments and therapies work within the contexts that they're going to be practiced in, and work with the people that they're going to be practiced with. And so sometimes when we take these therapies and put them in a new setting, like community-based mental health or like the LGBTQ plus centers I work with, they're not a good fit. The providers don't like them, the kids don't like them, people People don't show up. There's not the funding infrastructure to support them. So that big, long adaptation, implementation, dissemination science is really all about how do we take these therapies and fit them within the ecologies of the settings where they're going to be used. And to do that, and do that well, you have to partner with all layers of that system. You have to understand the kids' needs, their families' needs, the therapist and providers' needs, the administrators' needs, the stakeholders at the state level. How are they going to fund this? How is it going to fit? It's really layered. And so the biggest thing that I have learned is that I need to be selecting the methodologies and the approaches that are going to best serve me in integrating and paying attention to the multiple voices that are in these systems, so I can redesign, tweak, adapt these successful strategies to best fit. And you can't do that if you don't understand the voices of everybody in that system.
Yeah, so it's really, this sounds like a very comprehensive approach that pays attention to those contextual issues or structures in the community, and as you said, different levels of agents and actors, the families, legislators, and the larger context. And as that, it sounds like this may be more of a recent thing that is enabling some new opportunities or new successes and intervention. Is that right?
Yes,
Yeah.
yes. So I started out as part of my postdoc project about 5 years ago now. I received funding from the American Foundation for Suicide Prevention to adapt the attachment-based family therapy I was talking about before to fit within the ecology of LGBTQ plus centers. So the idea is, how do we adapt the delivery of this model so it can be used in the settings where it can be most effective for this population? And in that process, we learned that there were quite a few challenges when it came to accessing care. A lot of my colleagues in LGBTQ plus organizations had a lot on their plate. There were a lot of youth with high needs, not enough providers to go to, not enough referral sites that those folks trusted to be affirmative and accepting of those kids. Their biggest fear is, we're going to refer one of our kids out somewhere else. They're going to have a bad experience. They're not going to feel supported. And then they'll have no place to go. And so they were really sitting with this critical problem. And so when I came here to Virginia Tech, I kind of had two choices. I could either continue to advance the adaptation of attachment-based family therapy, or I could try to address this more critical problem of healthcare access and the expansion of care. And so what my current grant, recently funded from National Institutes of Mental Health, the idea of that one is to create a partnership program between LGBTQ plus community centers and child and adolescent psychiatry. We're working with Carillion and we're working with Diversity Camp, which is a wonderful local organization for LGBTQ plus youth. And the idea is, how do we formulate a partnership so that we have a stream of referrals where youth feel supported, where our LGBTQ plus experts can educate our psychiatry residents, get them well equipped to work with the kids, and create a partnership that is going to identify, refer, and effectively treat youth who are struggling with suicide.
Now that's remarkable. I really am curious about how some of your journey happened into this professional career, and wondering if you might take a moment to reflect on what experiences you had, what type of of learning or motivations shaped your path to becoming someone who is now a professional researcher, someone who's helping to develop at a practical level the solutions that can provide support that in many instances can actually save people's lives or help them to flourish and to be healthier. So what were some of the things that took you on this journey in your professional career?
Sure. It's interesting. It's not kind of a straight and narrow, but let me tell you, my path is I always knew I wanted to go into the helping professions. I was always interested in working to address health issues, particularly mental health issues. And so I did my master's in counseling psychology, which was all about the study, at least at my institution, about individual processes and how to bolster people from within. And I had the opportunity in my master's to work at a site where we were working with pretty severe cases, kids that were on a pathway to hospitalization, but were coming to see us because they were going to be diverted from that, hopefully. And in that site, I had the opportunity to do individual work, group work, and family work. It was my first time seeing families, having multiple people in the room and trying to organize processes, help them understand the problem. And in my own experience, I just found that the change in the kids that I worked with was exponential when we did our family sessions. It was profoundly impactful in ways that, for me, I didn't see in the group or the individual setting.
Okay.
So I then decided I want to go into family therapy. I had the choice to attend psychology programs. I knew I wanted to do intervention research too. Psychology programs or family therapy programs. And I went to family therapy because I just became so invested in this idea of the family cultivating change. And so when I was at Drexel University, where I did my doctorate, I was influenced by many mentors there, but I worked with Guy Diamond, who was the developer of this attachment-based family therapy. And you know, in Guy's center, we were treating the most difficult cases, people who were referred to us from the Children's Hospital of Philadelphia and the schools and community mental health centers. Whenever somebody had a case that was difficult, they would send them to Guy. And I fell in love with the model. I fell in love with the approach. It was microanalytic. It was systemic. There was a clear path of how to intervene, but yet it took into account clinical judgment and flexibility. And I just saw myself flourish in this model, and I saw my families flourish in this model.
Okay.
And so I really fell in love with the work. And I've always been interested in working with and doing research with LGBTQ plus communities, and so the opportunity came along for me to start to adapt the delivery of this model for that population, and I was all in.
That's inspiring. No, that's great. Well, you know, sometimes I am at different places outside of academic context. It could be a family reunion, or I'm somewhere with kids and adults are talking, and there are all kinds of people there, and people ask what I do. And I've gone from giving the long, 15-minute thing to trying to get something down to 30 seconds with varying success of just trying to explain. But when you are with different audiences outside of your own professional context, how do you explain what you do to people in a way that helps them to appreciate what's at stake and kind of get an appreciation for what you do day to day?
Yeah, I'm still working on that 30-second one, but this is a good practice for me.
Academics can't say anything in less than 30 seconds, but we try. We can't even count to 30 in less than 30 seconds.
I know. I think it comes down to one of the ideologies that I hold for myself and that I talk to my students about. And that is, as a clinical researcher, somebody who's studying interventions, I always am a therapist first and a researcher second.
Okay.
And that relates to what I do essentially, because my whole job is about relationships. Creating quality relationships, setting people up to have more effective, meaningful, heartfelt conversations about the questions that matter. Helping folks to build their tolerance for emotional intensity so we can address what the critical issues are. And so whether that's working with a student one-on-one, whether that's creating relationships between providers, whether it's working with one of my supervisees to provide the best care for their client, it is all about cultivating a space where collaboration and change is possible. And that's what I study, that's what I do, that's what I try to live by the best I can.
No, that's great. Yeah, in a few minutes we're going to invite any of those who are viewing to send questions that they might want to have a response to. But I'm curious about what are some of the points of consensus or lack thereof around different areas of your professional work that either has, maybe it's shifted over the years, maybe there are insights that have galvanized consensus among experts over different areas. But as you think about your field of work and some of the research that's happened over the years or different approaches that have prevailed from time to time, do you see one or two places where there's either been a lot of contention or it's been very difficult for experts to get a consensus? Or do you see one or two areas where there has been a strong resonance of, oh yes, we've learned enough now to recognize that this is something that we can really agree on as a best approach? What's your sense of the field?
There are many areas. There are many areas of disagreement, contention, or trying to figure out how to coexist with different philosophical approaches. But one that has been particularly important to me, and one that I've thought a lot about, is where is the intervention point? Is it in the individual? Is it in the family? Is it in the society where discrimination or othering is kind of a rampant practice? Where is our intervention point? And folks may have different perspectives on this, but I think a lot of our contention comes from, well, I study this intervention point, but you don't. You should be studying this. No, you should be this is where the change is. And I think I've come to the point where we need all three. We need all of them because we have a growing national problem. We have to help the people who are currently experiencing suicidality in the immediacy. And we have to address those societal mechanisms that are creating discrimination, othering, and marginalization, particularly for LGBTQ+ youth, that are perpetuating this. But I don't think it's a one or another thing. I think we need all of it.
And before we go to our audience questions, are there one or two things that are especially bright points for you as you think about the work you do? A lot of it, and this is clearly very heavy material, and there's a lot at stake. They're not always very positive outcomes. And so that weighs heavily on someone, and other times there are. But if you had to identify one or two things that you look on and see, wow, this really is a very positive thing that boosts my sense of excitement about why I do this work. What are those one or two things?
I think what always keeps me going is you know, I've sat with great pain and sadness, but I've also sat with incredible progress, openness, and change. And I have to say, especially in my attachment-based family therapy work, I am always humbled by what families can do, how parents and caregivers can transform from being angry, resentful, burned out, disengaged, to being able to access what they had hoped for their child, to access the feelings of sadness, loss, or longing that are essential for connecting them to their child. And for children, you know, I work with adolescents, so I see kids sitting in the corner, arms crossed, hair in their face, you know, not looking at you. But to see kids transform and really open up about what they need from their parents and reach for them in a way that they haven't been able to, and to witness, to help a family get to the point where they can reach for each other in that way, is just the most beautiful thing you will ever see. And that's what keeps me going. It's the work in the family, but it's also seeing my supervisees cultivate this. It's seeing my students cultivate this, and professionals who are trying to bridge relationships be able to do that same process. So it's really rewarding work when you get to see the power that happens when people actually connect.
Yeah, no, that's moving. I'm just picturing that as you're talking about being in the room with those families and seeing those connections happening that can make all the difference in the lives of these young people. We have some questions for our audience, and one of our viewers is asking about the role of teachers. And I'm wondering if you could speak to what you think are important ways that teachers might be able to implement some aspects of this. The viewer's wondering if that can be translated into different programs of suicide prevention or other ways to support students or young people who might be struggling with this. You have any advice to share?
I have many thoughts.
Okay.
I love this question because in the suicide prevention world, we see teachers as like the core gatekeeper that is going to be able to be attuned enough to kids to notice something's wrong, make the referral, and help the kid connect to care. And so teachers are just fundamental when it comes to preventing suicide among adolescents. One thing that I have been learning from my research and talking with teachers and folks in education about is how do we continue to engage the family? How do schools leverage the family in helping kids follow up with care? So we know that when a parent or a caregiver is on board with referring a kid to treatment, can drive them there, can motivate them to get there, they're more likely to go.
Okay.
And so I'm always talking with teachers and educators about how do we bring in the family and how do we get them on our team so we can make sure we follow up with the kid. So that's an ongoing conversation.
Yeah, no, that I think it's important to consider that there's so much time that young people spend at school, you know, around the teachers, around other students, and those teachers have the opportunity to observe things and be of support and intervening as well. You know, there's another question about the role of the pandemic in all of this. We opened with some reference to this. You were saying that the need to provide support to LGBTQ youths and other young people who are dealing with trauma, with depression, with suicide, that's always been there, and the pandemic has put a lot more pressure on those things. Can you say more about some of the impacts of the pandemic on both young people themselves, and then also on what has happened either at institutional, professional levels to try to intervene.
Yeah, that is a complex question, and I'll start with where the pandemic found a lot of us. I think for our young people, many things could happen. That people had different situations, but some of them involved maybe going back to a household where there was quite a bit of conflict already, or disconnection, and the need to stay inside, to isolate within this context. Difficult situations became more difficult.
Okay.
Some kids did not have a space to go back to, and were isolating alone. Wider systems had difficulty reaching and interfacing with these youth, because at least in the psychotherapy world, many of us were limited when it came to telehealth, and so we had to scramble. I mean, I remember us at the Family Therapy Center, we started calling our seminar room the situation room, because we were just in there all the time trying to figure out how to recraft our policies and HIPAA compliance to be able to see people remotely. So what I had always worried about, and still worry about, is that gap between the isolation, the disconnection, and when we were able to get ourselves going with the telehealth strategies to reach people. I think that left people alone for quite a while, and our young people alone. And so when I think about the individual situations, I go back to the role of isolation, and I think about the limitations of our healthcare systems to reach people in that period of time.
Yeah, it's really striking you bring that up, because I think it makes a big difference when we think about the implications of telehealth within this context. So as I've been listening to you, Jody, one of the things that you're emphasizing is the importance of those networks, people who are caregivers, who are familial, who are very close. And it's fair to say that even before the pandemic, people have often been, because we're more mobile now, you jump on a plane and go live somewhere else in the world that you couldn't do that 100 years ago, that people could easily be spending a lot more time by themselves, and the pandemic increased that. And there are many advantages to the ability to work remotely, for example. But one thing that is an implication, as you're raising, is that if being isolated, if the dispersion that happens and that has increased post-pandemic is creating situations where people are spending a lot more time alone, and they're already struggling emotionally, that requires some deliberate intervening, because that can make a difference, right? And so telehealth, I've heard telehealth talked about as a very important way to extend the delivery of care to people who live in a very small town. I'll give you an example. I grew up in a small town in Mississippi that used to have a traffic light. It used to have a railroad stop. The train would go, this is a long, long time ago. You could ride the train somewhere, and it used to have a doctor's office. And that's long since been gone. And so for places like that, it's now possible for people to get a medical appointment without having to drive 55 miles somewhere to a doctor's office. But I'm thinking about this in light of what you're saying, that while that might work, that remote telehealth could work for some people, it gets a lot more complicated if part of what is needed is actually in-person connection that can make a difference. So, maybe we can end here. I'm not asking you to predict the future or anything. If so, I would be asking you about tomorrow's lottery ticket number or something. But rather, as you just think about this work from your experience, and you think about some of the challenges that our institutions are seeing, that these young people are facing, And as we do have more ability to benefit from remote technologies, and we also have more opportunity to be deliberate about what we do and how we do it, what are some, maybe one or two pieces of advice that you might offer as we are looking at this future and as we're facing decisions that we'll have to make about, will we do more telehealth? Will we try to create more in-person experiences? So what are one or two things that occur to you that we should be mindful of as we move into that future?
I actually think about this quite a bit.
Okay.
It's one of those things that keeps me up at night. And I think I'm where a lot of people are, which is, how do we navigate this new world? What's hybrid? What's in person? What's online? What is the most meaningful platform? And I have to say, you know, the approaches I use are deeply interpersonal. It involves parents and kids looking at each other in their eyes and discussing some of the hardest questions and being there for them when they do that every step of the way.
Okay.
And there is a power in that that probably cannot be replicated when it's in person. I mean, if we think about attachment theory and the way we're wired as human beings, we respond to each other's faces. We can feel each other's energy. We can be attuned to each other when we're in person in a way that we cannot be when we're online. So there is an element of that, but you bring up this really important question about healthcare access and reaching people. And we cannot ignore the amazing work that has been done to adapt interventions, even emotion-focused interpersonal interventions, to be done on Zoom. Now, I just don't think we have the data yet or the experience yet to know how they hold up to the in-person interventions.
Yeah.
But I would hope that we could continue to honor the importance of the face-to-face interpersonal connection and try to cultivate that to the best degree possible within the circumstances that make sense. So it's not really an answer, it's just what I've been thinking about.
Yeah, no, that's actually very helpful. It's a lot to consider. Well, I want to thank you, Jody, for taking time to talk with us about the really amazing work that you're doing in working with LGBTQ youths, helping to support their well-being, really developing the tools and the resources that can help them to flourish, that's going to help our society to flourish. And it's been great to just learn about some of the things that brought you to this work and how it's moving forward. Really excited that you're part of what's happening here at Virginia Tech. And we want to thank those of you who have joined us. This has been really exciting to learn about your work.
Thank you so much for having me today.
All right, thanks, Julie.
Thank you.